Welcome everyone to this very important session. We're focusing for the rest of the day on mental health, right? This is a topic that we need more focus on. So welcome, I hope you tune in. We have with us Professor Gerard Hutchinson. So Kieran will do a short introduction and then we'll proceed.
Okay, so Professor Hutchinson is currently a professor and unit lead in psychiatry at the School of Medicine, Faculty of Medical Sciences in the University of the West Indies. He also currently is the coordinator of the DM Psychiatry, St. Augustine Campus and University Examiner in Psychiatry. He functions as the head psychiatry and mental health services at the North Central Regional Health Authority, where he oversees inpatient and outpatient mental health services of the NCRHA. He is also the coordinator and co-founder of the Stress Relief Center, which offers the only walk-in public sector counseling service in the English-speaking Caribbean. He's a graduate of St. Mary's College, the University of the West Indies, and the Institute of Psychiatry, King's College, University of London, and the London School of Hygiene and Tropical Medicine. He has authored and co-authored over 130 academic publications and is a member of the International Association of Suicide Prevention, as well as the World Suicidology Network. He serves on the Research Advisory Committee of the Caribbean Public Health Agency and is a manuscript reviewer for over 25 international journals. He is an academic editor as well as a member of the editorial advisory board of several journals. His published work has over 8,300 citations. Welcome, Professor.
Yes, hi, good afternoon, everybody, and thank you for the invitation. I think the focus of the discussion this afternoon is mental health in the context of sickle cell disease and blood disorder generally. So I'm going to outline the issues that I've engaged over the years, both in terms of practice and of course in terms of the reading and reviews of the literature that I've done regarding this
definitely
area.
Say, Professor.
And
I'll definitely say that so far for the week, in most of our sessions, mental health has come up at some point, right? So we started with the neurological issues.
Right.
Dr. Ebony Lance, she spoke about integrating like psychological counseling and other elements of mental health in care of pediatrics and noting that it really made a difference. It came out in pain management, the stress and the anxiety, and even in legal says stress was deemed a significant factor in the length of time for healing. So it definitely has been a trending topic throughout the week, the discussions we've had for the week.
Yeah, but even in also there's a suicide incident. Just want to mention that.
Yeah, mental health I think has become a very trending issue also in the context of the COVID-19 pandemic. I think people have increasingly realized how important one's state of mind is in dealing with the challenges of life and dealing with challenges that are either unexpected or excessive. And people with blood disorders are likely to be engaged in dealing with a whole lot of adversities in life because of their chronic medical condition and the nature of the condition, the fact that you have recurrent episodes where you might need hospitalization, where you have pain crises, where you have concerns about your mortality, where you have concerns about passing it on to your children. So there are lots of areas that that contribute to the mental health distress that accompanies these disorders. But also, I think even more significantly, and I think this is an issue that we tend not to engage, is that the disorders predispose people to developing mental health difficulties or mental health problems. But people who have mental health problems in the context of these conditions, as you were pointing out earlier, it means that the condition itself is negatively affected, whether it be having to be hospitalized more, whether it be having more painful crises, whether it be having greater resistance to treatment, whether it be having difficulties with relationships in your life, whether it be having an increased caregiver burden for those who need additional care. So whether it be disclosing the condition to people who you're engaging in relationships with. So the 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 relationship is bidirectional. So the condition predisposes you, but then the mental health problems then predisposes those with the condition to have a worse experience of the condition, and with accompanying consequences for morbidity, meaning that they are sicker, but also for mortality. So it's been shown that people who have depression, for example, in the context of blood disorders, and not just blood disorders, other illnesses as well, have much higher utilization rates of hospitalization. They need higher doses of medication for whatever condition they're being treated for, and they die younger than those without depression, as one example. So it's really a very important and I might say critical component of awareness that has to be communicated across the board, and that communication has to be not just to the people who have the condition, but to the people treating them as well. Because again, what we found is that the uh, physicians, the specialists who treat blood disorders, not all of them are entirely sensitive to the need for mental health intervention. And I think it's important on both sides of the equation for that sensitivity to be present. I think the expression of those mental health issues again can be also quite wide ranging. So people can have difficulties with sleep, they can have difficulties with their energy level, of course, they can have difficulties with their mood, they can have anxiety attacks, they can have problems uh, um, with their ability to relate to other people. They might become socially withdrawn, socially isolated. Uh, and in some instances where the condition might affect their brains directly, because they may have infarcts or blood compromise, blood circulation compromised to their brain. They can even have psychotic experiences, as well as experience cognitive problems, meaning loss of memory and loss of cognitive function. So the areas within which mental health issues arise for this population are quite numerous. And the interesting thing is that once it's treated, or once there's intervention, whether that intervention is psychotherapeutic, meaning counseling or psychotherapy, whether it's medication where necessary, whether it's a combination of the two, the outcomes generally are much better. And with a particular reference to children and adolescents, it is even starker in that population, where it's been found that because of the challenges of dealing with the disorder, the social challenges, the physical challenges, children and adolescents have a much greater risk of developing anxiety and depressive symptoms in the context of blood disorders. And again, for children not fully understanding the way a society works, they also experience these disorders as stigmatizing. They might be teased about it. Um, they might be ostracized even um, because of it. And as a result, the importance of helping them manage those things becomes important. And again, the first step to that management is awareness. So awareness in their parents, awareness in their treatment providers, so that the appropriate intervention can be made. So I think the idea that your brain and your mind are so they're like the thread that knits all areas of your life together, both in terms of the physical things that you do, but also the way you interpret the experiences that you have and the way you plan and create a trajectory for your life. It means that your brain and your mind need care. It needs attention, much in the way that your body needs attention, your physical body. But I think we're only now beginning to acknowledge how critical that is and why it's important to pay attention to that to that aspect of our being. And again, interestingly, the two things go together as well. So as the saying used to go, a healthy mind in a healthy body. But the other side of that also works, that um, if you have a healthy mind, your body is likely to be healthier. If you have a healthy body, your mind is likely to be healthier as well. So attention to your general health, the fundamentals, diet, getting enough sleep, getting exercise, all those things, even in people who have conditions that might limit their ability to fully engage in exercise, for example, um, would they should still be encouraged to engage in whatever exercise is possible, and of course engaging in things like meditation and things that nourish the spirit and the soul, so to speak, have also been found to be important in mitigating against the negative mental health effects of these conditions. And indeed, for anybody trying to live a more optimum or a more optimally satisfying life. So the the idea is to encourage people to pay active attention to these things, so that the health of their mental apparatus is constantly maintained. I think one of the other things is self-awareness, and again, that is something particularly in the modern world or the contemporary world, where we have so many distractions um, in terms of activity, social media, uh, the the need to kind of keep one's attention constantly focused on something outside of oneself. The need for people to become more self-aware, I think, has become much greater. And self-awareness, I always say, is like the first step towards mental health. In other words, you have to spend time and invest energy in understanding yourself, in being able to appreciate the things that make you feel particular ways, understanding the triggers, understanding that you are able to control your responses to things, and that understanding that within your mind lies the power to literally direct your life. And to do that, you have to understand how your mind works. And of course, your mind, as the function or the functional output of your brain, is what makes you individual, is what makes you who you are. So there's no, while there are guidelines that can be followed, like I said before, related to eating healthily and sleeping well, and often doing physical exercise, stimulating your mind. Those are general guidelines that would help anybody. each person has to identify the things that are particularly relevant to their own mental state, and that can only occur if they spend some time exploring and interrogating themselves. And of course, that is even more important in people who are dealing with adversity in the way that we began, and somebody with a chronic long-term illness who knows that this illness has the potential to upend their daily life, to make the things that other people might do quite nonchalantly very difficult and very challenging. It means that the challenge to understand oneself and understand how one can deal with the adversities that come with having a disorder uh, become even more critical. And that also applies to understanding the disorder and making the effort to know everything you can about it, so that that knowledge allows you to manage it better. And again, that curiosity, that drive to engage the available information in a way that allows you to build that self knowledge should be a fundamental part of one's development. I think that with regard to the service providers, I mentioned that many service providers don't appreciate the value of mental health, and particularly with regard to people with blood disorders. We often have issues with people coming in with pain crises, for example, and the service providers seeing them not appreciating the degree to which distress occurs in that context, and dismissing sometimes the concerns of the individual on the premise that they are exaggerating, or that they're faking, or that they are not trying hard enough to cope. And even if those things were true, and most times they're not true, but even if they were true, it would also reflect uh, an issue with their mental health. In other words, their capacity to deal with the condition that they have, and they would benefit from a mental health intervention. So I think it's we should be organizing to ensure that people are routinely screened in the services that they use to determine whether they have mental health issues. Talking before the session began, we were talking about the stigma that is associated with going to a psychiatrist. But I think if we frame it as mental health help, or getting a mental health checkup, or attending to um, the health of your mind, I think people will be perhaps less reluctant to engage in that kind of process, recognizing that helping themselves in that way will not only help them mentally, but also help them physically. And I think um, the the clients, the people who are using the services, have to also make the effort to engage that, so that they can push the providers who are not so inclined to be more aware of the need for that kind of mental health awareness and mental health input to the person's care. Um, we like to say that people who have chronic conditions, they are affected they can be affected in three ways: the condition itself, and how it affects the body, the uh, psychosocial responses to the condition, and the effects of having to deal with a condition um, in in society, and putting burden on caregivers, and of course sometimes the treatment of the condition in and of itself can create mental health difficulties. So that's a good framework to kind of use. Is this the disease itself? Is it how the disease is affecting my life in whatever frame, whether it be at home, whether it be at work, whether it be with relationships, whether it be my ability to engage in hobbies or activities that I like to do. whether it's my relationships, whether it's my need for support, whether it is how I'm seen by the public, and being able to understand that helps you then to narrow the focus on how it can be dealt with. And of course, whether it's the treatment, we just talked about what happens with service providers. Is it that? Is I've many times heard people saying that they don't really like to come to hospital, or they, coming to hospital is the last resort because they don't like how they're treated. They don't like coming to clinic. And again, addressing that is important because sometimes those visits are necessary. And if you don't engage them, it means your physical health and the evolution of your disorder would suffer as well. Is it how you're seen? Is it how you're treated? And we have to encourage people to be empowered to address those things. If they don't like how they're being treated, if they don't like how they're being um, how their function is being affected by the way they are engaged by the system, then they should organize themselves to make representation to have that changed. And I think that's a big part of taking ownership of your health. And I think that is something that is going to happen, but we have to encourage people to do it because I think that's a central part of your mental health as well, feeling more in control of what happens to you, and recognizing, of course, there might be occasions when you do not have that control, but being
So what
able
would you say
to
are the main
use that control when you have it.
what would you say are the main issues that persons who live with blood disorders have to deal with, the main mental health challenges that they may face?
Well, I think the in diagnostic terms, I think it would probably be depression is probably the most common one. But many of them also have anxiety, um, anxiety attacks, anxiety disorders. Um, some of them would substance use as a means of dealing with it. I've had several patients, for example, who use marijuana for pain control, but of course, eventually it gets to a point where the use kind of goes beyond pain control. Um, and you have symptomatic issues. Sleep is a big issue. I find many people complain about having problems with sleep. Many people, of course, have problems with things like their energy levels and fatigue,
Yeah.
which can be due to the disorder or can be due to depression or a combination of the two. So
Well, I
those are
mean,
the kinds of things we see most often.
I have seen a few programs earlier this year that have linked sleep disorders with well, persons with sleep sickle cell having sleep disorders specifically.
Yeah, yeah.
So
Yeah, it's
some
one of in fact, it's interesting.
go ahead, go ahead.
Go ahead. No, I was going to say it's interesting that two complaints that have really exploded, I would say, in the last 20 years in general, both in terms of physical and mental health, I think are specifically applicable to blood disorders. One is pain, and the other is insomnia, sleep problems.
Okay,
And I
I
think the
have
value of sleep has become much more obvious.
yes, definitely. All right, I have a couple comments here. Right, the first person to
Sure.
one of the things they said is they have concerns where people don't believe when they say that they're in pain, and I think that was in relation to what you were saying about not wanting to go to the hospital. Right. Someone
Yeah.
asked, do you think a psychotherapist should be a part of the hematology clinic and be a part of the protocol of treatment, like at least twice a year or even more as necessary?
I mean, a simple answer would be yes to both. Um, I think that the the first point about people not believing or not fully acknowledging pain complaints, I think come from a lack of understanding or ignorance among the treatment providers. Um, and that's why I was saying that it's important that persons identify the need for some mental health intervention to assist with that. And of course, in many of our health settings, the engagement with the physician is brief,
Yeah,
and therefore the opportunity to talk about stuff is limited, even in the
I agree.
emergency setting.
I agree. So
So
somebody's asking what are the signs or symptoms to look out for regarding depression and anxiety, especially in younger persons with an IBD.
so I think the most important one would be a change in their daily pattern of behavior. So if you notice somebody is normally outgoing and you find they're not talking so much, or they're not um, asking or doing the things, asking about the things or doing the things that they normally do, I think it is a sign that something is going on. Now, that doesn't necessarily mean they are depressed, but it is something to engage. And I think many times we are hesitant to ask people directly about their mental health because sometimes I guess we might be afraid of the answer.
Mm.
But I think it's important to engage the person if you notice these changes. As we said, changes in things like sleep, appetite, um, activity levels. So people you find who are complaining a lot about being tired all the time, people who are complaining that they're not able to do the things they're normally able to do in
Yeah,
terms of their energy levels. I think those could be signs of depression. People who are extremely irritable, so you find that they're getting angry very
mm.
quickly and more so than they would normally do. So who complain about noise. So you've always had children playing outside, but all of a sudden the children playing outside irritates them because the children are too noisy. Things like that are signs that the person is decompensating in terms of their mental health.
Yeah, but
So
some of those things that you mentioned came up in I think when we were discussing neurological issues, and the doctor was talking about I think it's executive control, right?
yes,
And that being a common issue in the younger population, right?
sure.
So and that was one of the reasons they identified integrating psychological counseling from a younger age.
Yeah. Well, going back to the comment or the question that the person had earlier about having a psychologist or psychotherapist as part of the treatment team, I
Hmm.
think speaks to that, that
Yeah,
that the presence of that person would then allow for concerns, because also remember that sometimes people are afraid to talk about the things that are bothering them because they they don't want to engage the system more than they have to.
well, I mean,
And
I could say to that, well, as a warrior myself, that sometimes one of the issues, because a lot of people say that we stay quiet or we suffer in silence, right? But I
yeah,
think for a lot of us, especially when we're younger, we may sometimes feel like a burden,
yeah,
and
yeah,
we don't want to place even more of a burden, especially to your caregivers, and that's sometimes why you suffer in silence. But I have a question related to what we're discussing in that. Um, we know that well, I can speak for sickle cell because I have sickle cell, but I know
hmm,
we have a condition where you could have some serious complications like strokes, avascular necrosis, right? There are others, right? But some of these things impact your daily ability to do things that you would normally do, right? So my question is that shouldn't it be that, especially those more serious instances, that it should be an automatic thing, more or less, that at least you should send a person for some sort of basic counseling and assess their state at post event?
Yeah, oh yeah, definitely. But you see, again, our systems, meaning our health systems, have are only now really appreciating the those needs, those kinds of needs. So what would
Mm-hmm.
happen in the past is that unless it was really blatantly obvious that there was a problem, or unless the person made an explicit request for
Mm-hmm.
something like that, it wouldn't be done. And as we were saying earlier, even for the person making the request, the worry that in making the request they would be looked at as mad, or um, somehow not in control of um, their mental faculties,
Yeah.
or so there's that kind of um, invisible debate going on regarding dealing with things like counseling and referring people for counseling. And that's why I was saying that if you think you need it, you should say so, and you should insist on it, even if the person is if the provider is reluctant.
Yeah.
And at the same time, we have to insist that these services are part of the routine delivery of care to to your population, because if it's not there, it becomes much harder. And I know we have to talk a bit about how the public mental health service works,
Yeah.
but even that has become a bit more accessible. I mean, still a little problematic, but it is far more accessible than it was even 20 years ago.
Yeah.
So So it's not that difficult to engage with the public mental health service. So working at ways to integrate the two, I think, are important. But I think um, there must be pressure, or gentle prodding, or maybe not so gentle prodding, coming from the population to make it happen.
So how do you suggest what would you suggest society needs to do to get greater attention of mental health integration into the care of our members?
Well, I mean, I think that um, writing to the the various providers of hematology services. I don't know, with the um, death of Dr. Charles, what has happened to the hematology clinics, who's running them, and
Mm-hmm.
all of that. But certainly writing to them, writing to the CEOs of the various regional health authorities, making them aware of the need within the within that within the PPU within the people you represent, and its absence in the care that they currently access. Um, Even making public appeals,
Mm-hmm.
because I think that the needs are likely to be acknowledged and responded to sometimes when they're in the public domain, as
Yes.
against just kind of private or administrative urging.
Mm-hmm.
So I think those are the things that can be done. Of course, organizing workshops, um, both for doctors, for nurses, for social workers, for psychologists, and engaging in that kind of um, bi-directional conversation.
Yeah.
Identifying the various associations and letting them know that this is a real issue for your population, um, and of course, doing uh, communications campaigns, particularly around times like what you're doing now, what you'll have been doing all this week,
Yeah.
um, to sensitize both the people who know about it, meaning yourselves and your caregivers and your relatives and friends, but also to sensitize the wider public as well.
Yes. We have some questions. So someone says one of my challenges periodically on work is getting people to put the disease in perspective. I have been told by persons in authority that I am a good worker, but I'm always sick when I want to be considered as just a good worker, despite of my illness. I have stopped trying to explain myself.
Well, I think again that is ignorance on the part of the employer, and again I think employers are not always very sensitive to these things, and they would argue, some of them would argue that I mean their responsibility is getting as much work done as possible, and if somebody is not um, has a high or a higher than average rate of absenteeism because of illness, then that person has to sort out that problem. It's not their responsibility.
Yeah,
But I think that again, education about the condition, education that this is something that just like how people get get other illnesses, it's not the person's fault, and the person is doing the best they can, and when they are able to do the best they can, they do work well. So it's really about finding ways to accommodate that person. For example, what has happened with the COVID pandemic, people have been allowed to work from home.
yes,
In the past, if somebody had said, well, I have childcare issues, or I have somebody to take care of at home, and I prefer to work from home, that wouldn't have been possible. But now, in the context of COVID, all of it, people realize it is possible that people could work from home, or people could work more with more flexible schedules and all that kind of thing. So I think it is about again education, and using the society and other means of support to engage organizations, people like the Chamber of Commerce, all those kinds of entities, to appreciate that it is not that you don't want to work, it's not that you can't work, it's just that because of your condition, you can't work in the same way, or perhaps at the same intensity all the time as somebody who doesn't have the condition.
Hmm. Someone asked, how can we cope, especially in light of COVID? What mechanisms can we use?
Well, this is why I was making the point about about self-awareness. So
Hmm.
really understanding yourself. Now, it might seem kind of, well, how can that help? And many people think they understand themselves, but haven't really actively explored themselves. And I mean, that's one of the ways therapy helps. Um, to really ask yourself questions about who you are, what you represent, what makes your life meaningful, what is your purpose, um, why do you try, why do you make the effort to do stuff. And of course the answers to those questions might change with time, so that's why it's an ongoing process, but it's the first step to understanding how to deal with adversity. And coping is ultimately about being able to manage adversity. And the three steps in that process are: one, accepting the reality of the situation, and in accepting it, accepting what you are able to control and what you are unable to control, and being able to make that distinction clearly. The second thing is committing to managing as best as you can, but maintaining a certain degree of mental health and emotional stability. In other words, telling yourself that I'm going to manage this, that I'm not going to let it overwhelm me. And of course, the third step is finding the tools to do that. And like I said before, the tools vary with the individual. So some, it might be prayer, it might be dedicating themselves to prayer. Some it might be listening to music, or picking up an instrument that they used to play before that they put down. Some it might be taking walks. Some it might be, picking up some kind of hobby, drawing or painting. So it might be fixing things around the house. But the point is, with all those things, is to dedicate time to it. So if it's prayer, you dedicate time in the morning and in the evening to engage in that. If it's meditation, dedicating time to do it. So it becomes a part of your your life and not just something you do when you're stressed. And I think
would you say
that's
peer groups might be a good idea? Peer groups can help?
peer groups, yes, of course, peer groups are, but again, you have to find a group. I mean, and the idea of being in a peer group is with people who are able to provide support for each other.
Mhm.
So it's identifying a peer group that you feel comfortable in, that is not that doesn't become an additional stress.
Yeah.
So so it's like some clients of mine formed a book club, for example.
Yeah.
But you can't join a book club if you don't like books, or you're not willing to learn to like books.
Yeah.
So those the few of them who found that they like to read and they like to talk about what they read, they formed a book club, and they found that has been extremely helpful for them during the pandemic. So it's about, and again, that's why I say it's so important to understand yourself, so
Yeah.
that you know that this is something I will like or something I'm interested in, and I'm willing to make the effort to engage in it. And I think that applies to peer groups. You have to find a peer group that you fit into and that you feel comfortable in.
Yes. Definitely.
So maybe I could talk a bit about the public mental health
Yeah.
services.
Yes. Yes.
Okay. So the public mental health service is defined by geography. So as the first point to remember, so that depending on where you live, there are services that uh, that have been set up to help people who live in that area. It's called sectorization. So there are, I think, 7 sectors in the country. So the easiest one is San Fernando. So San Fernando is a sector, and it starts from Couva and goes all the way down to Point Fortin and Fyzabad, everywhere south of Couva.
Yeah.
So in each sector, there will be health centers that have days when they have mental health clinics.
Okay.
So mental health clinics in the Couva Health Center, in Pleasantville Health Center, in Princestown, Fyzabad, Sipari. So if you call the health center, you can ask them, okay, what day is the mental health clinic? And on whatever day it is, you can go to the clinic, and usually they would want a referral, but depending on your problem, they might see you without a referral if it's a serious problem, or they might write a referral for you. So that's the outpatient service. There you'll see a psychiatrist. Some of them have psychologists, not all do, and all of them have social workers. So they would be the team that would manage those mental health clinics. Then, if admission is necessary, the first port of call would be the psychiatric unit in the San Fernando General Hospital, which is Ward 1. And again, you can access that through emergency. So anytime you have a psychiatric emergency, or you think you need to be in hospital, for example, for somebody who is suicidal, you can go to the emergency department in San Fernando, and there's always a psychiatrist on call who will be able to come and see you. Of course, given COVID, there might be some delays in terms of seeing the person, but the service is available. And then after they see you, they might decide you do not need to stay in hospital. They might refer you, depending on where you live, to one of those clinics.
Okay.
In the south area. Then heading north now, the next sector is the Shogunas, Canupia area. And on Thursdays, there's a clinic in the Shogunas, well, what used to be the Shogunas Health Center. It's on Endeavor Road. So the Shoguana Cell Center has moved now, but the mental health clinic has remained, and it's there on a Thursday. And again, the same thing applies there. If you're seen there, you will either be referred to come back to the clinic, or if you need hospitalization, you'll either be referred to the psychiatric unit in Mount Hope here or in St. Anne's, again, depending on the problem. In addition, we also now have what we call stress relief centers. One of them is on Endeavour Road, and they are open every day, Monday to Friday, 8 to 4. So again, if you have a issue, like if you feel overburdened, if you feel overwhelmed, you can go to the stress relief center, and a psychologist there will see you. Because of the demand for that service, it had started purely as a walk-in service, and again, depending on the problem, you might still be seen as a walk-in client, but because of the demand, they're now giving appointments because of the number of people who
Yeah.
have accessed the service. So that's in Shoguanas, and that they cover that area between Couva and Moncton. Then here in Moncton, Eric Williams Medical Sciences Complex, we have two clinics on a Monday afternoon and a Wednesday afternoon, from 12 until 4. And you need a referral to come to those clinics, but we also have an inpatient unit called the inpatient unit, and it's called that, so it's not called a psychiatric unit. And if you come to the unit, you can talk to one of the doctors, and they will write a referral for you to join the clinic. We also have an emergency department, so that again, in case of emergency, you can be referred to the psychiatrist on call. And again, there's a psychiatrist on call 24 hours a day, every day. Then heading east now, you have a psychiatric clinic also on a Thursday at the Tacarigua Health Center on El Dorado Road, and you have a psychiatric clinic at the Arima Health Facility every other Wednesday. And again, the same things apply there. Heading towards Port of Spain, you have a clinic, it's called a wellness center, in fact, in Barataria on the Eastern Main Road, 5 days a week, every day. Don't see a psychiatrist isn't there every day. The psychologist isn't there every day. But once you go in, they'll see you. A community psychiatric nurse will see you and arrange for you to see either the psychiatrist or the psychologist. And then in Port of Spain, there are no dedicated services in Port of Spain apart from the Child Guidance Clinic, which sees children up to 16 years of age. That's on Pembroke Street. It's on the block between Gordon Street and I think that's Keith Street. That's the
last society's office.
Right. So that's the last block on
that's right after the
Pembroke Street. Correct.
Yeah.
So they see children up to 16 years, and again you can walk in, talk to somebody, and they will advise you how to proceed. They take referrals from schools, from parents, from other doctors, from hospitals. Because it's the only clinic to serve that population, it can be a bit overburdened. So, and again, depending on the problem, sometimes the waiting time to see somebody is long. But again, if you make a case, they usually try to facilitate people. Then, of course, there's the St. Anne's Hospital. Again, people view St. Anne's in a certain way, but I'll tell you a quick story, a quick anecdote. A friend of mine who worked in the Ministry of Community Development when it used to be in St. Anne's, I don't know if it's still there, but she was having some difficulties with life and work, and she decided one day to walk up to St. Anne's to talk to somebody. She said, well, if it's a mental hospital, she may as well go up and see what they had to offer. And she did go and she did see somebody, and she told me it was a very pleasant experience, and she advises everybody to do that. So people don't often realize that you can walk into St. Anne's. There is a 24-hour emergency service, and usually a mental health nurse or a social worker or a psychiatrist is available to talk to you. Again, depending on the time you go, there might be a wait. For example, if you go 1 o'clock in the morning, they might have to call somebody out. But once you go in daylight hours, you'll see somebody pretty quickly, and they're always willing to talk to people. So I know going to St. Anne's has a stigma.
I know good to say, in the old days, they used to say St. Anne's is the madhouse, right?
Correct.
So if you tell somebody to walk into St. Anne's, I think of all the centers that you call, as the one people may be most reluctant to go to.
And this is why I gave this story, because she, I mean, this friend of mine wasn't, she didn't think she needed to be admitted, or
Yeah.
she was just going through a hard time and she needed somebody to talk to. And
Yes.
she figured, why not try it?
Yeah.
And it was a very positive experience. So that's what I'm saying. Sometimes our concerns, and I mean, the concerns are valid concerns, certainly not to say they're
No,
not
no, no,
valid.
no. I think that's the thing with most persons who live with blood disorders. I'll say, because there are times that we all go through a bit of hard times. I know, like for instance, for thalassemia patients, I think just the idea of having to go and wait to find out if you could get a pint of blood and you do get it, and you're doing that how many times for a week, and
Sure.
you're not successful, that alone can place a mental toll, right? And then for persons who live with sickle cell, live with the pain every day, and sometimes, like let's say you get an ulcer and it changes your life or changes your lifestyle or your ability to do the things that you're accustomed doing.
So, I mean, one of the other things that has come out of the pandemic is that many groups have been willing to offer hotline services, telehealth, video call type services. And I think that maybe is something, I know in the past we have talked about that in the society, about being able to provide um, that kind of service where somebody who's undergoing a particular difficulty can call a number and be sure that they can talk to somebody.
Yes.
So maybe that's something we could explore as a potential means of dealing with that. But also in mental health, well, this the concept came out of mental health. There was something called a case manager. And this case manager could be anybody in the system, could be a nurse, could be a psychologist, a social worker, anybody. But this person managed that, in inverted commas, case. So in other words, if you had a problem, so like how you talked about having a pain crisis and you want to know what to do, you could call this person and this person would direct you, or they would call whichever service and say expect so and so, because they're having this problem. And it's something that we've been thinking about how best to introduce it, because of course we don't have the human resource to provide as many of those kinds of managers as we might need. But I think it's something that is necessary. Somebody who in groups like Alcoholics Anonymous and Narcotics Anonymous, well, Alcoholics Anonymous was the founding group. They have a concept like that, and they call it a sponsor. So when you join the group, you get a sponsor. And this sponsor is somebody who you could call anytime, who commits to taking your call 24 hours a day and guiding you when you're going through rough times. So I think that we could talk about some kind of hybrid where people have that kind of access to someone who can help them navigate those difficult circumstances, or indeed navigate going to the hospital. They could go with them, or they could, give them some kind of support when they have to make the trip to the hospital.
Professor, it would be great if you could help us as an organization or reach out to clinical psychologists who may be willing to offer discounted or free sessions with our membership who would need to talk to someone.
Sure.
And even if it's on a group basis.
Sure.
Or even private, which may be preferred. I don't know.
Well, again, as Kieran was saying before, some people might not want to
be in a group.
Be in a group, or want to publicly express that they are, or express that everybody else knows that they're experiencing distress. So we could find ways around that, but certainly we could look at that. And I know that there are psychologists who'd be willing to extend those services.
That would be wonderful.
So
I came in late, so if I say something that was said before, my apologies in advance. So I'm putting my.
That's okay.
I want to create a scenario. There are two components. I was talking to someone once about funding for organizations like the SILBD and otherwise. And some of the difficulties that people ask, like, what is the data that supports the claim that some people do X, Y, Z. But the bottom line suggestion was you only need to destigmatize these IBDs, most of sickle cell disease. So people understand that it's a condition and it's not something to be scared of. That's one. So we're talking about even dealing with people who are looking to put their money into supporting programs, corporate or public sector. That's one. In Tobago, there's presently a compulsory acquisition going on of land to improve now you're probably wondering where I'm going with this. Improve the quality of the airport, the existing airport facilities. Now, both central government more so is selling it as a big improvement for the island and all that kind of stuff. But here it is, we have an officer of the law relating a situation where after someone's house is taken down, this person sits on a bucket under a tree for at least 2 weeks. And the officer asked them twice, why are you here? Your house is, I don't know where to go. And I can't believe my house that the only place I knew since I was born. This probably in the late 30s, late 40s, maybe 50s. I don't know where to go. And that's their result, to sit on a bucket under a tree and look at the space that they used to have. Then further up the age bracket, where people who have been free and clear in terms of their lands for maybe upwards of 30 years, otherwise inheriting lands. And the mental health component, I'm not sure if the public health sector is part of that acquisition, because people are having a real challenge. Now, is that a reality, or is that something that we are making up in terms of how people are relating, how they feel? People are having very euphoric reaction, like I mentioned, the person sat on the tree. How would you, first of all, describe that, and secondly, suggest? So I mean, it's coming out of the IBD component, but there are people living with IBDs dealing with that. I know of at least one or two persons. Yeah. So that brings it back to the context here for today. How would you describe it, and how can one, deal with that?
So I think I think there are three aspects to that are important in terms of devising a response and explaining it. I think the first, of course, and relating to IBD as well, is when you have a condition like this, like I said, that's chronic, long-standing, difficult to cope with, it's very hard to identify with people who don't have it because they don't know what you experience, and they can't know what you experience because they don't know what it's like. So therefore, it's natural that you become more or let's say less engaging or less desirous of interacting, because it's like almost like a secret that you have that you don't want to share, because as Kieran had said earlier, you also don't want to appear as if you're complaining or that you're a burden or anything like that. But that in itself now creates a kind of helplessness too, because you also have to let people know when you need help. And our systems, unfortunately, only work or only seem to work when you tell them that you want help. In other words, we don't have a system, whether it's healthcare or even social services, where you reach out to people and say, how you doing? What's going on? Do you need help? If you don't put up your hand and say you want help and shout and bawl, you're likely to be ignored, unless it's so obvious that it can't be ignored. So that, and even in terms of dislocation, as you talked about the guy in Tobago, or being treated in a particular way when you have an IBD and you come to the hospital, the sense of powerlessness and helplessness can be quite overwhelming. So it is important that you're able to say, look, I need help, and find ways to get that help, even if the traditional ways especially if the traditional ways are not working. And then the third component now is the wider society. How do you get them involved? Because as I said initially, they don't know what you're experiencing. They and many of them might not care either, because it's not something that they personally have to engage with. But I think that, and going back to the point about asking psychologists to provide services, unless unless we engage them, unless we go to them, meaning, as I was saying before to Kieran, when it's public campaign, social media, whatever, you have to write in articles in the papers. You have to find ways to reach that wider public,
Yes. Okay.
so that they can be aware of what you're experiencing. And maybe 99 people will ignore it, but one person might say, oh my God, I never knew about this. Let me see how I could help. And with that, that might grow into something more powerful. So to sum up, it means a combination of feeling more empowered, or finding ways to feel more empowered. And I guess that's where things like this, that's where organizations like the society can help. And it's about addressing the needs, saying this is a need, and we have to have it addressed, and looking for avenues to have it addressed, both with it from the service itself, but also from the wider public, in terms of making them aware that these needs exist, and have to be met.
So you mentioned the word empowerment. I just want to jump off on that a bit. Quick question about, is it practical and secondly safe to have members who are comfortable coming to someone like you, or your team, or your unit, or anywhere in the island, and be trained, well, getting help or understanding how to, like going to the dentist and how to manage your mental health and so on, and then come back in the SISPD, but under supervision of someone who has the experience to talk to our members, probably in smaller groups or in larger groups, because they feel more comfortable with their own kind. How practical is an approach like that? I mean, it could lead to a bigger solution. But how, I mean, to start off, I talk about something that can start like next week or 2 weeks, so you don't have to wait for all the,
The red tape.
yeah. I try not to say the word, but how practical is that?
Well, again, it's certainly possible. I mean, certainly I'd be happy to engage in that process. The I mean, in technical terms, you're really describing peer counseling, but it's more than that. It's akin to what we talked about before with the sponsoring AA, or the case manager in mental health care, where you have people within the organization or within a group who have these skills, or who learn the skills to take back to the group, and help the group navigate difficult situations, and also know, okay, well, this one requires something more than I could provide. Um, but yeah, we could certainly explore that. And again, that's an example of saying, well, okay, this is something we need. How best can we make it happen? And um, I'd certainly be open to making it
Okay.
happen.
Well, I mean, I didn't specifically ask you, but if you are offering, I'm not going to say no. But and this is if I aside we did take on. But there's a question here from Anonymous. I don't know if it was taken already. What can cause bipolar disorder? Hasn't this been answered already?
No.
So this is from an anonymous attendee.
So bipolar disorder is a mental health condition, used to be called manic depressive illness. And the simple answer is nobody knows. I mean, which could be the subject of a talk on its own. What causes people to develop these conditions? What is known is that there is a heritable component, meaning that if it's in your family, the chance of you getting it is greater, but it doesn't mean that it's inherited, meaning that because, let's say, your parent has it, you are going to have it. It just means that your risk is greater than average, or greater than the person who doesn't have a parent who has it. And the thing that causes it to be expressed, I guess, again, described simplistically as developmental stress. So if you're exposed to stress growing up, abuse, neglect, emotional turbulence, lack of a supportive environment, problems in school, bullying, and nobody knows how all those things combine, meaning that whether you need to have one thing alone or two things or three things or one thing at this level of severity, but exposure to those things in varying ways would then cause that heritable component to be more likely to express itself. And it usually presents for the first time in adolescence. There's also a hormonal component. So women, for example, who have postpartum depression, which is having depression after
Right,
they've had a
right.
baby, they're more likely to develop bipolar disorder down the road compared to those who have not had postpartum depression. And it's characterized, of course, by fluctuations in your mood. Sometimes you're down for no reason, other times you feel high and invincible for no reason. And the for no reason part is the key thing. So in other words, it's not that something has happened to make you depressed, but you just wake up one morning and you feel low. You feel like the world is a terrible place and you don't want to live in it. And then other days you wake up and you feel like you could rule the world and you could do anything. And you can't control those things. And of course, both sides of that coin are associated with the stress.
And is there a time frame for postpartum depression?
It usually presents
Last
within 6 months of delivering the baby. And it can last up to a year. If it lasts beyond a year, it might mean that it's becoming something else.
Oh, okay. All right.
So
It
but
can last
it
for
should.
several years.
Yes, it could last for a very long time. But if it lasts for more than a year, like I said, you're probably moving into now an independent disorder, like bipolar disorder or major depressive disorder. Or
Okay.
yeah.
That's interesting. And when people talk about it lasting longer, it actually could be true, but it's just the description would change because of the time
Yeah,
frame.
yeah. So the idea of getting postpartum depression is it's a reaction to the challenges of motherhood or parenthood and the hormonal changes that occur. So those hormonal changes would have settled down after about a year. And of course, it is assumed that after a year, you should be at least able to tolerate the challenges of parenthood. But of course, if there are other circumstances like you're being abused physically or you're in a terrible financial situation or you don't have a place to live or stuff like that, it means that the distress is likely to persist. Or the child is very difficult, the child has some problem that makes it very hard to parent the child, then
Right.
you know it could persist for a very long time.
Oh, this is not a popular conversation because, well, let me say it first. Right? Let me not put in any disclaimer. So the woman has had sickle cell disease. She has had a child. There's actually one of our community members who has 8 children.
Right.
And the last time I spoke to her, she was about 5 years ago. She was taking care of children alone. You know, suffice it that a lot of men stick around. And that may not be a popular statement, but a lot of men stick around. So they are SAS, and
Yes.
wife is AS or SS or SC, and they have a child who has sickle cell disease. So the wife it's almost like a PBL. So the wife,
Sure.
the child, so she's recovering. The husband also take care of the child, maybe children, and the wife. What is the description for postpartum in men? And does it exist?
That's
How?
an interesting question. So yes, I mean it's called the same thing actually. Um, it's not the of course um the big difference is that men don't undergo the same hormonal changes that women undergo, although there's some evidence to suggest that men do undergo some hormonal changes, but
Well,
not to the extent that women do. And basically that hormonal change is that there's a precipitous drop in estrogen once the baby is delivered. So um so that won't happen for men, but they do have changes in their estrogen levels during the pregnancy, particularly if they're very involved. Um, so men can develop both um, depression during pregnancy, during their partner's pregnancy, as well as in the aftermath of the baby's birth.
really?
The dynamics are slightly different, but again, they're informed by the challenge of fatherhood, and particularly fatherhood in difficult circumstances.
Right.
One of the predictors um, of postpartum depression in both men and women, independent of all that we've said regarding the hormones, is ambivalence about the pregnancy. And
What,
by
sorry?
ambivalence, I mean one of the big predictors, apart from all that I've said about the hormones and the challenges of parenthood,
Mm.
is ambivalence about the pregnancy, meaning that you're not entirely sure you wanted to have a baby, or maybe that you wanted to have a baby with this particular person. So the birth of the baby creates all kinds of conflicts in your mind. And again, that comes back to what I was saying earlier about understanding yourself and really spending time um, getting on top of who you are and what you represent. Because you have to accept once the baby is born that the baby is born, So
Yeah.
coming to that resolution is harder for some people. And for some people, that process leads them to become depressed. So it's not just the idea of fatherhood, it's also your relationship with the mother, it's also the issues with the pregnancy, it's also the implications of the pregnancy,
Right.
and the presence of the baby. And it's very interesting that infidelity, which is something that is said as a kind of folk tale, but the research does support it. Infidelity is greatest during pregnancy and in the early periods
Early
of
periods of
a, a,
recovery.
a new baby. Yeah.
So Don, let's define infidelity on the man's part. But
You broke up a little bit there.
so we want us to be specific. We talk about infidelity on the male's part. They're the ones who've stepped outside. That's what you're talking about.
Yes, but also even on the female's part.
Right. I just wanted to bring that to bear because I've heard those stories from the woman.
Yeah. Yeah. But even on the female's part, which is why I say it's interesting.
Right. No, so you shouldn't have grown up. As you're speaking these scenarios, these are stories coming from our community. Children have grown probably at least early 30s. The question from a caregiving father who was wife with sickle cell and probably two children with sickle cell trait. That's one give you a scenario. Is asking, is it fair for me, the parent, the father, to expect my children, to expect our children, not mine, because they were very specific about the question, to expect our children to do what I do for my wife, so they have to do for their mom? Is that a question reaching out for help?
Well, yeah. I mean, again, I think one of the greatest, if not the most important law in life is that you can't legislate for other people. And once a child becomes an adult, you really can't legislate for what they should do. Um, and I think obviously one would want to create an environment where if something needs to be done in terms of caregiving, that the children would instinctively want to do it. Given the example of their parents or the people who they've seen. But I do think that you can. So
Yes.
in terms of I don't think you can expect it, and I don't think it would be fair to the children to expect it. Um, but it does create, and of course, it can create a lot of conflict, but it also does create that whole that burden of expectation, which in itself can be a cause of people becoming depressed and having mental health difficulties because they don't know how to manage this burden that they're carrying or are made to feel that they have to carry.
Okay. The other side of the coin now, where the person with sickle cell disease, this is my choice rather than using the word sickler. So the person with sickle cell disease, the PSC, has grown now. They now have a child with the condition because they birthed a child with a partner who has the trait or disease.
Sure.
Relationship has ended. They are solely responsible for this child, and they have a parent with potential trait was not tested, now exhibiting issues. And they now have to take care of themselves, their child, and their parent.
Right.
And they're presenting with a lot of issues for probably 2 or 3 years. How can that affect them, I guess, psychologically, emotionally is a question. And how can they expect to get, I guess they have to ask for support, but what kind of help do they need to get?
Well, again, I think caregiving is a burden. Whether you manage it well or don't manage it well, and having to take care of people on both ends of the age spectrum, children and older parents, is definitely challenging. So I guess again the question is where is the psychological issue coming from? Is it that burden? Is it that you're just overwhelmed, you don't know what to do, you're tired, you're pulled in too many directions, so you need help in terms of maybe getting somebody to help with the parents while you focus on the children, or vice versa? Is it something deeper, emotional thing? You really don't think that you should be doing this because you want to do other things, and this is bogging you down and holding you back, and you feel that you know you shouldn't be in this situation. Or it might be that you feel that either one of them, going back to your previous question, that the children are not grateful or the parents are not grateful for the effort that you're putting in, so you're developing resentment for doing it and not getting the kind of reciprocal um, respect and support that you expected. So I think it depends on understanding why the psychological distress is occurring, and I think seeking help psychologically might help you to do that if you're not clear about it. And then depending on the cause, I think the intervention will be more will you'll be more aware of what kind of intervention you need, whether it's just purely help, meaning physical help, another pair of hands, or time to do other things so that you get somebody to come and take care of one or the
Take a
other
break. Yeah.
for a period of time, or whether it's something, like I said, more deeply rooted psychologically that you have to resolve in your own mind. That would then lead you to, having resolved it, would then lead you to take action
Okay. Well, I'll
to
do two things.
overcome
I'm
it.
going to hand back to the co-host, well, the host, Mr. Blackman and Ms. Dale, and I'm not sure if any the other attendees have questions, so I will just mute and ask them to jump back in.
Well, what I will first say is that for the attendees, raise your hand if you have a question or if you want to ask Professor Hutchinson or make any comments directly. Raise your hand and we'll come to you. Don't be shy. All right, okay. A hand just went up. Okay, Jillian.
Hi, afternoon, doctor.
Hi, good afternoon.
Nice having you on the program. Thanks for being here.
My pleasure.
You mentioned the place in Shogunas. You mentioned the one on Endeavor that didn't move with the health facility.
Yes.
is it both that you have to have a referral letter to?
So the stress relief centers opposite, in fact, they're opposite each other. So they're on the same road and opposite each other. So the stress relief center you don't need a referral to, but the psychiatric clinic, which is the one in Anchor Villa. So the stress relief center is on the right if you're heading towards Montrose Road, and the Anchor Villa is on the left. So the one on the left, you should have a referral, but if you go on a Thursday when they have clinic, somebody will see you and help you navigate the system. So the stress relief center is a psychological center, so you don't get medication there. You get counseling and therapy. Anchor Villa on the left is where you would get medication if you need that. So,
Okay,
but
thanks.
that's only on a Thursday. The Anchor Villa, the psychiatric one is only on a Thursday, whereas the stress relief center is every day.
So you mentioned about, well, I live with sickle cell, and
Okay.
not having a support system over the years have been very difficult.
Right.
So my question is, have you seen persons who who live with sickle cell who has really bad mental conditions?
Yeah, I have.
To the point of being medicated for it.
Yeah, oh yeah.
Is that a developing issue over the years for them to reach that state, or?
Well, again, I think each individual case has its own peculiarities. In some instances, yes, it's people who've been coping with it for a long time and just have grown tired or have become overwhelmed by the constant demands. There are people who have very frequent crises, so it might be a response to that. There might be people who have social situations, they live alone and have no support, they have financial issues, they can't get a job, they can't support themselves. There are people who have a history of mental illness in their family, and because of that they can't get the support because their caregivers are people with mental health problems, so they uh, uh, find it harder to cope. There are people who use drugs excessively, who have alcohol problems, or who smoke a lot of cannabis, who sometimes use other drugs as well, who have difficulties as a result of that, and require more aggressive, for want of a better word, mental health intervention. And there are people who have physical problems too, like I think Kieran mentioned it. They might have avascular necrosis, or they might have had a heart attack, or they might have had a stroke. Um, and in the aftermath of that, they've developed mental health problems. So I've seen all of those. So it's really a very individual thing. Although of course, for each of those, I'm sure there are several people who might tick some of the boxes.
Okay, dealing with the health care, and you mentioned it early on. No, we don't like to go to clinics. No, we don't like to end up in
Right.
A&E because
Hospital.
sometimes we meet doctors there that dismiss us,
Sure.
and it adds to our mental state, not in
The
a very
stress.
positive way. They just add, instead of adding something positive to the situation, having our crisis and things like that, it's very negative.
Sure.
So why is it that our medical fraternity don't understand that mental health is part of their job?
Well, that's a big question, and like I was saying, in the past, mental health has always been seen as a kind of, even within medicine, has always been seen as a kind of thing for mad people, and not, and that having being mad automatically means you're less important. So that's one reason. The second reason is that the provision of services, of mental health services, has not always been consistent in the past. So that even when you pick up somebody with a problem, you don't know what to do, where to refer them, how to refer them. All of those things have begun to change. They haven't changed completely yet, but they've begun to change, and I'm hoping that with time they'll change further. But I think the other big thing is that in general, and it's kind of related to the point I made about you having to say that you have a problem before you get help. Um, People, especially working in the healthcare sector, I can't speak to other sectors, but people working in the healthcare sector generally will not do more than is asked of them. And unless you ask for more, they're not going to do it. Um, and I'm not saying that that's the way it should be, but that's the way
Yeah.
it has been.
You see,
If
this
I
is
could
one
just
of the
check,
reasons why I asked before, Professor, about after certain types of events or challenges that some sort of counseling at least should be an automatic thing. And I'll use myself for an example for a moment, right? I had a stroke at the age of 22, right?
Right.
That left me paralyzed. The immediate aftermath of that was extremely difficult to deal with because I went from being a fully independent young man to dependent on everything for my parents, even as simple as going to the bathroom or brushing my teeth.
Sure.
Right?
Sure.
So that the initial part of it was difficult, right? Now, one of the things that in itself also motivated me to do my best to get up. That dependency. It really drove me to try to learn to walk, and because I needed for myself to regain a certain amount of independence. And being able to do that and starting to go back to school and things like that helped. And
Right.
maybe it was a distraction, and that took away me thinking about that dependency, right? And perhaps now, being an advocate and getting involved, that also takes me away from any negativity that may arise. But I must admit that maybe at times it might be good to talk to someone, right? But the thing is, I'm not the only one. There's so many of us who go through different challenges that really it changes your, it brings an immediate change to your life or your lifestyle or your normal way of living. And that in itself, I think, is where the mental challenge really comes.
I wanted to just add that to what Chilean was saying, that I read recently that generally the health system and the medical fraternity, they treat the conditions like sickle cell and the blood disorders. They treat the disease, not the individual.
Sure.
So that is, yeah. So they will overlook, the how we cope and what other struggles we have apart from the clinical manifestations. So that's why we have to work as a group to try and make them aware of that and try to change that.
But it's not every doctor, because when I go to clinic, every clinic appointment that I have, I need to see a psychiatrist after, because it's that bad.
Right.
It's
Sure.
I
And
I
is it
don't have good experience at all. But I know sometimes it's a personal thing, because once in a blue moon, you may meet a doctor that has a wonderful personality and a caring heart and a wonderful spirit that he or she will treat with you differently. But for the most part of it, it's like I need to see about my mind after clinic. So I hate
right?
clinics.
So, and I agree with you that, and well, I should say that yes, I agree that I was going to say I agree with you that it's not every doctor. Some doctors are great and are very aware, but it shouldn't be. It should be a systemic thing. So in other words, whoever you see, you should be able to get that kind of response. But unfortunately, that isn't the case, and that's why I was saying that the group or um the group being a group is more powerful obviously than an individual, but you have to be, I'll use the word again, empowered to challenge the system to provide what you need. And I'll give you an example of that. The Medical Research Foundation, which treats people with HIV, they now have a clinical psychologist on staff because the complaints about addressing mental health issues, they had social workers, they had nurses, they had physicians, but the need to have somebody on board who can deal with those issues when people come to the clinic became so pressing that they had to go and hire somebody to do it because the clients complained, and the fact that they kept having to refer people to other places, and sometimes when they made the referrals, people weren't seen, or they didn't know whether they were seen or not, or they had bad experiences where they were seen. So they decided that they would have somebody come in house. So that's an example of putting pressure on the system to create something that is needed. And I think that's the if the pressure isn't put, the system is not going to shift its response even when they recognize that it might be needed. As I said, unfortunately, that's how our system works for now. But that pressure has to be has to be put on the system. I can give you another example with our clinic. At again, going back to the mental health, the way mental health is treated. Some years ago, they closed our clinic because they said there was no space and to house the clinic, because the space we were using was earmarked for something else, and they began building and stuff. And the patients used to come to the clinic, wrote to the minister and wrote to the CEO and and the chairman of the board of the region and said, well, no, we want this service. And eventually a space was found. So even when there is a clear need and benefit is being had by some people, the system or the people who operate, who run the system, sometimes feel that that need can be made secondary to other needs, and and feel that it's okay to just dismiss it. And unfortunately, mental health is one of those things that when services are being cut, it's one of the first things to be cut um, in in the system.
What are your thoughts on mindfulness, and do you think it is widely used here in Trinidad?
Well, its use is increasing. I mean, meditation in general has become quite a big thing. Um, as you all might know, there are now quite a few apps that utilize it or allow you to access it. There are mindfulness-based workshops all over the place. Um, so the simple answer is yes. I think it is useful or can be useful. Again, I think you have to. It's not entirely. It's not universally useful. Some people don't engage with it very well, so you have to know whether you're one of those people. And of course, the only way you can know that is to try it and engage it. But I think generally speaking, it is quite helpful. And meditation in general, I think has become a lot more widely used and accepted. Even yoga. Like I wasn't even aware that there's something like 15 or 16 yoga schools in the country now. When I was training as a doctor, which is a long time ago, I think there was one, and even that was kind of shrouded in all kinds of secrecy. Now there are about 16 schools, and perhaps there are even more that I don't know about. And that's
Yeah.
because one of the people who run a school came to see me and showed me they starting an association of only people who run yoga schools. So, and for there to be so many, it means that there must be people accessing the service.
Mhm.
So things like that have become, as I said, much more accessible, much more utilized, and definitely have a place in maintaining both mental and physical health. And I encourage everybody to at least investigate it, check it out, and see if it works for you.
And any questions or comments from anyone else in the audience?
Yeah, we have plenty things to talk about, but I just want to ask Professor to comment on that, whether it be a response in terms of answer otherwise. People also, I've heard in one of the islands of the Caribbean, so not in Trinidad, has some level of suicide rate when dealing with ulcers. And you're familiar with ulcers with sickle cell disease?
Yeah.
So this person was relating that there's a suicide rate, and then there's another incident that happened here in Trinidad. Someone after multiple crises, whatever level, they took their life by leaving the hospital without going down the stairs. So I know suicide is the ultimate, but how common or real is that in our community, seeing that you've been exposed to us for so long? And I just want to add that you are someone who knows Dr. Waving Charles very well.
Yes.
Right. I think that's important that this community knows that, because you were at the 2017 symposium, and I knew only the best of the best around the world were there, and that's because of Charles. So I'm saying that to say is that anyone who knew her, especially in historically, would really have a passion, if not for inherited by the soil, but for doing the kinds of stuff that people would need to have done for them in medical field. All right, so I hope you remember the question I put out. Suicide, right?
Yeah, so I mean, again, so suicide rates are generally high in people with chronic illnesses across the board, particularly chronic illnesses that are, in inverted commas, incurable, meaning that you have to find ways to live with them, and particularly with chronic illnesses that have the risk of either physical complications or severely limiting in terms of activity and lifestyle complications. So people with ulcers are one of those that applies to that group. People with particularly harsh sickle cell disease, that applies to them, or thalassaemic disease. So the risk of suicide is greater, and that's one of the reasons that mental health support is needed. Help mitigate that risk, and that risk is in some ways independent of depression and mental health or a mental health diagnosis, because for some people it just becomes too much. It just becomes they've just had enough, constantly deal with the health complications of their condition. And there's no easy, if there's any answer at all to that. And I guess it comes back to the point you all have been making about routine support, helping people to cope better, helping people to find a purpose in their life that would allow them to have the strength and the courage to keep dealing with the issues related to the condition, supporting each other as in the society and the peer support groups that we talked about, um, finding ways to advocate for better service, not just mental health services, but as you all have said, and that I know and I'm aware of, better treatment when you go to clinics, when you come to the hospital. I know there's no, again, easy answer to those things, but um, the ultimate, I mean, people say that whether you live or not is like the ultimate philosophical question. And if the answer is to live, then there has to be some reason or um, something that makes you want to live, makes you want to get up every day and say, okay, I want to go out there and deal with life. And again, everybody has to engage that themselves and find what that thing is or what those things are, and um, work at not being disillusioned by sometimes the storms and the negative feedback you might get from the world and the people in the world sometimes, and from your own body when it has to respond to the complications of the condition that you have. But ultimately, it comes down to that feeling that the purpose that you have should override having to deal with those um, those issues. And I think the decision or the state somebody gets to when they decide that they no longer want to live is something that we have to take seriously. And um, if in working with them, we have to, it's not just getting them to overcome that desire to end their life. It's about finding a reason to make them want to keep and stay alive. And I think that's where the challenge is. And it's certainly for many people no easy challenge. So uh, it's 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 part of the process, I think, of negotiating life with a serious illness that has the capacity in and of itself to end your life, meaning that the condition and its complications can also cause you to die. So it's not an easy thing to kind of come to terms with.
This is really multifaceted. My last input, not the last thing I have to say, but my last one for you would be, is it best for males to be paired or counseled together rather than males and females? Well, males and females done separately if you're doing a group.
Well, again, I think
Yeah. No, but there's another
I think
part
it
as well.
depends on the issues.
Mhm.
Okay, sorry.
I want to share the other part with you. And so besides those who live with the condition, so the caregivers we have identified need support as well. So can caregivers and the
Sure.
people assemble and get support, or is it best to separate it?
Again, I think it depends on the reason for providing the support. Simple answer is it is and it has been done. So there have been groups with caregivers and people with the condition meeting together and kind of sharing their experiences, because again, many times you, because you're dealing with the condition, don't appreciate what the caregiver goes through. And of course, the caregiver doesn't know what you go through, apart from what they see and what you might say or what they might guess based on your reactions. So being able to be open and put those things out for open discussion sometimes is helpful. Um, if it's about purely about support, it might be better for the caregivers to meet with themselves, um, in terms of ways to support. Uh, and in terms of gender, again, if it's about relationships, it might be better to have both genders represented. If it's about the illness and the issues, I mean, for example, one of the conditions that is not spoken about a lot is sexual health. And again, some people with uh, blood disorders have sexual problems
Yeah,
arising out of the condition,
yeah,
but it's not
priapism is one, yes.
correct. But it's not something that they're going to really talk about unless forced to, or unless it becomes um, so powerful that they don't have a choice but to talk about it.
Yeah,
But that is something that also needs to be addressed, because it is going to affect the way the way your relationship um, proceeds, the way you deal with yourself. It might affect your self-esteem. There are all kinds of ways in which it can impact on you.
Yeah.
maybe you might not want to talk about that with other males. So those, if you're dealing with that, you'd want to deal with it on in a one-on-one kind of context. So I think it really depends on the issue, and in organizing the group you should be sensitive to that, and determine whether the group should be mixed in whatever way, or whether they should be dedicated, or indeed whether people should have like one-on-one sessions with regard to the particular things. So I think there's no kind of formula for it. I think it really depends on the issue and the resources that you have as well.
But well, definitely, Professor, I could say that from the discussions we've had, well, it's clear that the society has some work to do in terms of writing and lobbying for greater integration of mental health into the care of generally persons with all blood disorders, not just sickle cell.
Sure,
Right.
sure.
And but I hope in that we could get supportive, influential persons like yourself, as well as the university as an organization, right? To lobby more for that support.
Oh yeah, I mean, and I have to say that we in terms of representing the university, we have not we have not been as forthcoming as I think we might have been, should have been. I could apologize on the basis of being distracted by other things, and but going back to what Kyle said about Dr. Charles, is something that Dr. Charles and I spoke about, or have been speaking about a long time, but we've never kind of sat down to work out the logistics and the mechanics of it. But I think it's the time has come for that.
Yes.
And certainly I'd be happy to work with the society to help in developing strategies to address it, and providing, as I think Kyle had suggested, providing opportunities to observe and train and get information about dealing with particular issues. All those things I think I'd be happy to work with the society to facilitate.
But it was very heartening though that because we did reach out to the Trinidad and Tobago Association of Psychologists for support with the next session, which is mental health for caregivers,
Yeah.
right? And we did get their support, even though it take a little following up. But
Sure.
They did come through, and we did get somebody who volunteered and came forward to assist us with the session, and we're really looking forward to that session later at 6 o'clock.
Okay,
right?
great.
But
I think
it's really good to see that the support is coming through, because I think there has been a feeling of neglect in the past.
Sure, and that's what I'm saying. I hope it didn't come across that I'm saying that the responsibility has to be yours to make it happen. So obviously it's a two-sided thing. But like I said, unfortunately, the way our system works is that unless you ask for it, you don't get it.
Yes. Yeah. Well, yeah. From experience, we know, because even things within the care system that we are in, even sometimes things within hematology, unless you're really busy seen by a hematologist like Dr. Charles, who has foresight and the wealth of knowledge that she had, sometimes you have to say to the doctors that are treating you, look, this, even if you prescribe this for me, I can't take this.
Correct. So it is. So it does require that. As I said, I use the word unfortunately, and hopefully with time it will change, because even advocacy generally is not something that we do very much here.
Yes.
And of course, there's the whole power thing, but I think the way forward is to identify what you need and ask for it, and go for it, as young people say, a full 100%.
Yes.
So that even if you don't get all of what you need, you'll get some of it. but you have to ask and push for it.
Right. True. Renee, have anything you want to add? I don't know if she stepped away.
Sorry.
We have some questions.
Okay.
I think it was just some comments.
Comments,
Steve,
okay.
Great discussion. And we would like if you could share your contact info.
Well, you could, Kieran has my email address. So you could, I think email is probably the easiest way. And some people always ask why email and not phone. And the reason why I like email is that you have a record so that you might get a phone call, talk to somebody, and then forget what you said. But with email, you could always go back to it and say, okay, this is what I said, or this is what we agreed on, or this is what was being asked for. So so you could share my email address. I'd be happy to communicate with anybody about also a message about the empowerment starting by the 28th.
His email address.
I'll have to look for it.
Oh.
Give me a moment. I'll put it in the chat before we close. Right.
I just wanted to say I sincerely appreciate the time that you spend with us, Professor, time and time again whenever we reach out to you for providing your services, your advice, chatting with us.
Yep.
Yes, as I said, it's my pleasure.
I apologize for the past.
Happy.
I want to apologize for the past laboring of your ears, but it's a good day today because I'm asking for a date now that, you know, if we can decide, if it's even just 3 or 4 will get together before the end of this month, that we actually start the conversation on how this, and this Mr. Blackman's term, peer-to-peer. This is not a term I normally use.
Right.
Can this peer-to-peer mental health team, you know, there's a rhetorical question. I'm just saying, I'm just making a comment that it's really good to hear all this happening and that, you know, we come to this point.
Yeah, well, we have one hand up. We have one hand up. I'll just allow Stacy to talk. Stacy, you should be able to talk. Yeah, you need to unmute yourself. Okay, go ahead.
The professor's email is in the chat.
Go ahead, Stacy.
Yeah,
your little things.
Okay, good afternoon, everyone.
Hi, good afternoon.
Hi, I really want to thank Professor for your discourse this afternoon. It was really interesting, and I look forward to collaborating with, well, the university and your department and the society, because I think it's something that is needed, and this COVID-19 experience that we are going through has really highlighted a lot of issues that were always there, but that just needed to be more in the forefront. And I thank you for your time and efforts. Take care. Bye.
Okay, you're welcome.
But I'll ask one thing before we close, Professor, even if it's not today, sometime in the near future. You told us a lot about the facilities available in the public health. If you could give us that information, like an email or something where we could post it for our members.
So what I could do is I could act as the go-between with the mental health unit in the ministry, because they have a big flow diagram that describes all of the centers and all of it. So I could certainly get them to send that to you. In fact, I was talking to them just yesterday about that. The fact that people want that information is very hard to get. It's supposed to be on the Ministry of Health's website, but apparently wherever it is very hard to access. So I'll put you on, as I said, I'll act as a go-between to help you get that information.
Okay.
And then you can publicize to your membership and wherever else.
Yeah, that would be very welcome. And I know today's discussion was very informative. It was very fruitful. All right. We have one more hand up. I will just go ahead, Julian.
Professor Hutchinson,
Hi.
it was a pleasure listening to you this afternoon. And I hope this is not the end, that we're going to hear more of you. Anything in the future that we plan to have that you will be part of.
Yes, I'd be
Thank you
happy
very
to.
much for being here today to inform
Yes,
us.
yes, it was my pleasure. And thank you for inviting me.
So you see what you're hearing there, Professor, is really an outpouring from the community itself. Because like as I mentioned,
Yeah.
speaking with members, I've seen the need has been there.
Yes.
Right. So I know a lot of the people who are on today are really happy to hear what they heard today, and especially in terms of the information and the ability to access the services. That is something that really we weren't aware. I'm sure we didn't know it was so easy in some instances. I mean, it may seem easy, and then when you go there, it's a challenge. But
Sure,
nevertheless,
sure. And I mean,
nevertheless, the information is really helpful, you know?
and with regard to Kyle's thing about a date, we could probably aim. So 2 days are pretty good for me. Next Thursday would be good for that meeting to start. You know, the peer-to-peer group or whatever, however you all want to label it. So at least we could, you know, kind of work out some kind of schedule and,
Yeah.
you know, see how we could get that up and running. So maybe just email me and we finalize that time. But yeah, so we could look at Thursday next week.
All right, great. Thank you for that. Well, it was really a pleasure having you on today, and so thank you for sharing the time with us and making this event a success. Right?
Well,
We're really happy for that.
yes, like I said, it was my pleasure, and hopefully,
I just wanna add that. Okay, sorry. All right, Prof. Go ahead. I'll
I was
speak
just
after
gonna
you.
say that as Julian said, the it should be a beginning, so that, or another beginning, so that we could, you know, work together to implement and concretize some of the stuff that we've talked about.